Kia ora everyone. In this video, we are going to learn about the myocardium. Let's start with thinking about what you need to learn. So these are the core conditions, and by core, we mean core. When you graduate medical school, you should probably know a whole lot more about the heart and myocardium than on this list, but this is the minimum that you should know. As always, this pathology that we do together is about clinical practice. Okay, so as I go through, I'm going to think about how what I'm teaching you is applying to clinical practice. I know that you have before in ELM learnt quite a lot about the heart. Here are your learning outcomes. I know that you've done a couple of lectures and tutorials. So first we're going to revise some key points from those. Let's start with atherosclerosis. So atherosclerosis is the response to endothelial injury. So step one is endothelial injury. And endothelium can be injured from a variety of things, but in particular due to turbulent flow, hypertension, lipid products, and advanced glycation end products from diabetes. And once it has been activated, it leads to inflammation. So atherosclerosis is a chronic inflammatory and healing response. The big arteries and the medium arteries are the arteries that are most affected. The veins and arterioles don't get atherosclerosis, but of course, arterioles get arteriolosclerosis, which we'll particularly talk about when we learn about diabetes. So these are the steps, okay, in getting from normal to atherosclerosis. And this slide is very small, I know, but it is actually from your previous learning. Remember how I'm always telling you to explain pathogenesis just by writing 5 steps down? Yes, this is the 5 steps. So there's 5 steps, and then we can expand on them, okay? So endothelial injury and dysfunction causes increased vascular permeability, which means that lipoproteins, mainly LDL, seep into the vessel wall, followed by cytokine release, which attracts inflammatory cells. And then with further cytokines, there is smooth muscle recruitment and growth, deposition of extracellular matrix, which entraps the foam cells, leading to the classic atherosclerotic plaque. Here's a picture where we've got this central necrotic foam cells with overlying smooth muscle and fibrous tissue forming the fibrous cap. Now, in atherosclerosis, there are stable and vulnerable plaques. So a stable plaque has got a really thick fibrous cap. And people with a stable plaque tend to have stable ischemic heart disease, which manifests as stable angina. People with vulnerable plaques, what they do is have unstable angina and progress rapidly to myocardial infarction, particularly if this thin cap becomes ulcerated. So this is the big idea here, okay? So hemorrhage into the plaque by new vessels that form in it, and also plaque ulceration or rupture leading to thrombosis leads to unstable angina and MI. Have a look at your old slides. All right, so previously you've also learned about the pathology of myocardial infarction and have got the concept that the myocardial infarct progresses, all right, progresses through days. So early on, right, you can't see any change microscopically, and there's just a bit of edema and hemorrhage there in the wall. At about 24 hours, you start getting infiltration by neutrophils. At about 3 days, what you get is actual proper necrosis, where you're having a yellow center. There's lots of neutrophils breaking down the tissue, and there's this proper necrosis. At about 7 days, what you get is lots of macrophages clearing out the necrotic debris. And then about 10 days, you get granulation tissue growing in. And it's in this period here that it's at its weakest. Okay, it's like a healing wound. It's this part where the macrophages have cleared up the necrotic debris, and the heart is just like a soggy mess in that area. Okay, and then finally, after several weeks, you get scarring. Okay, this is also another idea, and this is the idea about time is muscle. So initially, when there's a myocardial infarct due to an obstructed coronary artery, the inside of the heart undergoes ischemia, but this outside, this penumbra zone, can be saved if there is reflow. And so the idea about early intervention in myocardial infarction is that we save this muscle rather than let it go through to a complete full thickness infarct. Okay, here are some other big ideas. The complications of myocardial infarction are related to this, the progression of the pathology. So what are the complications? Okay, so acutely, the heart can just stop working because a large area is affected, or the area that transmits the electrical impulses is affected, and it leads to death by cardiogenic shock or arrhythmia. So this is what happens acutely. Maybe the myocardial output falls so low that the people die, or they get an arrhythmia. So what happens if a person survives the first 24 hours? Okay, so the next thing that happens is maybe they get pericarditis. There's two kinds of pericarditis that people get in myocardial infarction, and the first one is just due to the inflammation that is happening in the wall of the infarct, and this will manifest as a rub. So after 1 or 2 days, your patient there in the cardiac unit might develop a cardiac rub from the inflammation in the pericardium. And the next thing that can happen, and of course there is still a risk of arrhythmias happening in these early days, is that maybe there is myocardial rupture. So myocardial rupture happens when the myocardium is very soggy. Here we are, getting very soggy due to its structure having undergone necrosis and macrophages infiltrating in there and taking away the necrotic debris. So how can that manifest? So the person can have a rupture that ruptures outside into the pericardium. This is what it looks like here. We've got a heart, hypertensive heart. This wall's really, really thick. An MI is happened here, and blood has escaped here into the pericardium. Now, if this happens, then the heart can't dilate in diastole, and so it can't fill up. So this leads to pretty sudden myocardial failure and sudden death. Okay, so back here, this is called cardiac tamponade. It could rupture between the septi, so you get a right to left heart shunt. That's very bad for myocardial function as well. Or the papillary muscles can rupture, leading to acute mitral regurgitation. So the person survives the myocardial rupture risk, and then what happens? Well, all the inflammation inside the heart leads to mural thrombus formation. So mural thrombus happens when the inflammatory infiltrate in the endocardium is sticky due to the inflammation. There's lack of pumping, so stasis, and then the person gets thromboembolism. So it can go to the brain, for example, or the kidneys and give rise to infarcts. This is why post-MI, alterations in the clotting cascade are really important, antiplatelet and anticoagulant treatment. Late complications include ventricular aneurysm formation. So let's go back here and think about a collagenous scar. So this collagenous scar can be quite thin and it can just balloon out. Okay, and this of course makes the pumping really, really inefficient. What can happen next? All through here, and we'll just move this up a bit so we can see the slide, is heart failure. So many of these things can lead to heart failure, and the person might just not be left with enough heart muscle to be able to pump effectively and go into chronic heart failure. So chronic heart failure can happen in the months after an MI, left-sided due to inefficient pumping, and then also that puts the pressure backwards into the lung, leading to the classic features of heart failure, and then right heart failure can follow due to left heart failure, giving rise to the right heart failure symptoms. So those were all slides from your year 2. I hope that you're remembering things a bit more. Let's go through some points again. Okay, 30 minutes after occlusion, there is subendocardial infarction with islands of cells in the penumbra. Okay, 6 hours to extend it through the full wall. So lysis of the thrombus saves myocardium. A concept that was also introduced to you was about the territories. Okay, so one artery can get affected at a time, and where the artery is placed affects the myocardium. So of course, left anterior descending, you get the anterior part of the left ventricle affected. This is looking at the heart from the top. Circumflex lateral right coronary artery affects the posterior part of the heart. Will I be asking you to recognize pictures? No. But knowing the microscopic features descriptively and how these relate to the complications is so important that when you do your Cura Cloud revision for homework, you will cover that again. And just to help you think about it again, this is the timeline, right? So it's important when you're looking after people after an MI that you recognize when people go off what it might be. They're unlikely to have an aneurysm, for example, in the acute period. So here we go, going through immediately arrhythmia and contractile dysfunction, pericarditis, rupture at 3 to 7 days, highest risk of neural thrombus around 10 days, but lasting for a long time, aneurysm as a late complication, and also heart failure. All right, this thing called Dressler syndrome is beloved of examiners. So Dressler syndrome occurs 2 to several months after a myocardial infarction. It's pericarditis caused by an autoimmune reaction to the released antigens and causes inflammation in the pericardium. Okay, so let's think again about the heart. Okay, so we've done all this already. So arrhythmias, VF is the most common cause of death in MI from arrhythmias. It's particularly common in the first hours and common in the first 48 hours. But here, reperfusion frequently induces arrhythmias. So this is something to watch out if you are looking after people acutely. All right. Pump failure. Okay. So let's look at some more details around this. So left ventricular failure occurs if about 20 to 25% of the left ventricular mass is lost, and cardiogenic shock if around 40 to 45% of the ventricular mass is lost. So if it's a big myocardial infarct that hasn't been thrombolized early, this is a real problem. And mural thrombus over the infarct, especially in people who have, infarcted this endocardium, can occur, but this happens much later. This is what pericarditis looks like. We often call it bread and butter pericarditis, because if you think of two pieces of bread with butter and margarine on it and you pull them apart, it kind of has this appearance, okay? Acutely, and then later as part of Dressler syndrome. All right, this is the kind of question that you will be asked in your exams. So you just need to memorize that sequence. And you're going here, but I thought it was like, they told me it was, and here it is. Okay, 3 to 7 days. So when they give you a question like this, what do you do? 3 to 5 or 7 to 10? It's more likely 3 to 5 days, isn't it, rather than 7 to 10. But, sometimes the examiners won't choose time periods that exactly match up with your teaching. I think this one's from Cloud. All right, here we go. So this is another MCQ. I'm going to give you a moment to read it. I'm going to have a drink of my cup of tea. So remember, the first step to answering MCQs is to make a diagnosis. So this person is having, it looks like, a myocardial infarct. So what it's really asking is, which of the statements are correct concerning John? In other words, which of these statements are correct or concerning a myocardial infarct? All right, changes the scene in John's heart under a microscope 6 hours after attack. Well, apart from edema, that's pretty difficult to pick up, maybe not. Granulation tissue, 3 days, 10 days. John is at increased risk of ventricular fibrillation. Yes, but this isn't usually fatal in patients post-MI. Wrong. John is at risk of chronic right atrial failure in the future. Well, that's slightly weird, isn't it? But yes, he is at risk of right heart failure in the future. And John is at risk of acute pericarditis. So he is at risk in a couple of days. All right, so which ones of these are true when you're faced with this? Well, clearly we can get rid of this one, and this one, and this one, okay? So we're left with these. Which of these is more correct? Well, right atrial failure is a bit funny because we usually talk about right ventricular failure, don't we? So I think the answer is E. John is at risk of acute pericarditis, usually 1 to 2 days after the attack. Here's another one. Right, so here's Dennis. We know he's got a STEMI, and we know that he's got some heart failure 8 days later. Upon auscultation, a systolic murmur is heard best over the left chest. All right, so why might he have a systolic murmur? So let's think of those complications again. He might have a systolic murmur maybe because he has ruptured between the right and left heart, like it was a septal infarct, or he might have one because he has like papillary muscle rupture. So those are my best thoughts. Okay. He won't have cardiac tamponade because that would lead to instant death. He probably doesn't have APE because they aren't associated with murmurs. Yes, he could have papillary muscle rupture. Yeah, he could have that. Dressler syndrome gives cardiac rubs and does not give rise to systolic murmurs. So the answer would be C. Okay, so that is about MI. This pathology is really straightforward. My message again, please just learn that that sequence. Just memorize it. Like, test each other on it. just go, okay, 4 days, what are they going to die of? Till you've got it down pat, and then you'll be able to answer these questions. We're going to move on to something new now. We're going to move on to cardiomyopathy. There are 3 kinds of cardiomyopathy: dilated, hypertrophic, and restrictive. So dilated is the most common. Here it is here. The wall is thin. This is the heart is enlarged. This is normal. This is the heart is enlarged and the wall is like just thinned out like a balloon kind of blowing up. This is commonly seen in post-ischemia. And you can kind of, if you look real close at this slide, see the little white bits here. So this is when there's not enough muscle left to contract and the heart is just increasing in volume. The second is hypertrophic. All right, so this is when the heart muscle increases in thickness. There's 2 kinds of hypertrophy. The first is asymmetric hypertrophy, which mainly affects the ventricular wall and is commonly seen as an inherited disease. And the other one is concentric hypertrophy, which is commonly seen by infiltration or by hypertension causing the muscle to increase in thickness, just like over-exercised muscles do. The third one is restrictive, and I've just realized I've made a mistake. Just keep listening. That's the one with infiltrative bits. Okay, so hypertrophic, you can either have just wall thickening, which is inherited, or concentric, like in hypertension. Restrictive is when it gets infiltrative. Okay, so this is things when you've got like sarcoidosis and amyloid, and the heart just becomes really, really, really stiff and just like can't contract. Okay, 3 kinds of cardiomyopathy. Can you think of a mnemonic? I can't. If you can, just write it down. All right. So we've mentioned cardiomyopathy, commonest kind, commonly seen with ischemic heart disease. But here's some other things that can cause dilated cardiomyopathy. So the first one is viruses. So we know that people get viral myocarditis. We know because we've been through a COVID epidemic, but it was around before then. And what happens is the virus kills and disables myocytes and essentially removes them. They get replaced by fibrosis, and the heart no longer has that contractile ability and dilates. Or it kills so many of them acutely that people the heart just stops being able to contract and just dilates. So dilated cardiomyopathy can happen viruses acutely or chronically. Alcohol, of course, again, kills and disables myocytes that get replaced by fibrosis. So alcohol can lead to chronic dilated cardiomyopathy. Let's think a bit more about those viruses. So acute dilated infectious dilated cardiomyopathy is due to an acute viral myocarditis. So I have here mentioned COVID. Yes, COVID. We all know about COVID these days. Causes an acute viral myocarditis. Cells die. But other viruses as well, particularly the Coxsackie and echoviruses. It occurs in young people. You remember how even with COVID, the cardiomyopathy happens in young people. Young people's immune systems just get much more excited. And so if there are viral antigens in the muscle cells, then the immune system will attack them and kill them. I blame it all on the cytokines, which is true. All right. So here leads to myocyte death and fibrosis due to immune mediated injury. This is what happens. These are the myocytes. These are blood vessels. And now we have a whole lot of lymphocytes migrating out of the blood vessels to attack and destroy the viral, attack and destroy the myocytes because they have expressed antigens and cytokines have been released. This is a serious disease, all right? Very serious. So complete recovery of ventricular function, it says, in 50% of patients, which means that 50% of patients don't get complete recovery of ventricular function. Those people who remain injured, about 80%, about about 30% of them, so 80% of people altogether will survive, but they will have ongoing heart damage, which can lead to dilated chronic cardiomyopathy, and they may require heart transplantation. Here's a typical question. So this is the typical presentation of someone with viral myocarditis, a 20-year-old man who has a flu-like illness. Okay, we know a lot about myocarditis these days, a lot more. So all the people who have COVID, who are young, are told things like, if you become short of breath, or if you have arrhythmia, you should seek medical attention. These are the symptoms of acute myocarditis. But if they're ignored, people can die. And the typical findings in these cases are a floppy, dilated heart. And of course, we know that we would see lymphocytes infiltrating the heart and causing myocardial death. So here we go. This is the typical finding in a 20-year-old who's unlikely to have coronary artery disease. Let's think about some of these things down here. Iron deposition. So people who have hemochromatosis, who aren't treated, can get iron deposition in the lung, in the myocardium, and that can lead to a myocardial dysfunction as well. Quite often it leads to a dilated cardiomyopathy, and sometimes it can be associated with alcohol as well. Fibrosis, no, this happens over weeks, as we know, rather than dying suddenly at home. Granulomas is interesting. So granulomas typically here would be referring to sarcoidosis, which can infiltrate the myocardium and cause it to become stiff. So there is a really, really bad kind of acute myocarditis where you get a type 4 immune reaction with granulomas that can just lead to the heart stopping functioning and people go straight to ICU. It's got a very, very high death rate. Neutrophilic infiltrates typically would be associated with, of course, bacterial abscesses, which are rare in the heart, or a myocardial infarction. Okay. So let's think of dilated cardiomyopathy due to alcohol. Okay, so alcohol or other toxins. So other toxins that frequently affect the heart can be chemotherapeutic agents as well. And I guess iron would be part of those toxic ones too. So alcohol can directly inhibit mitochondrial oxidative phosphorylation and fatty acid oxidation, just like it does in the liver. And so the myocytes become relatively ischemic. They're hardworking cells, those myocytes, and die. Abstinence is the best thing that they can do. So here's a question. Here's an alcoholic who presents with progressive heart failure. I'm just going to correct my slide here. It is not happening. Maybe it is. We'll delete that. So there we go. His heart is enlarged and dilated, so we suspect he's got either alcoholic cardiomyopathy, or maybe he also has some coronary artery disease. Yeah. But no, his arteries are only 50% occluded, and you only really get coronary artery disease at about the 70% occluded level. So although he does that, have some coronary artery disease, it's probably not due to that. So what would we see at post-mortem? Well, we know that alcohol kills the myocytes. They're replaced by fibrosis. Here we go. The answer is going to be C, interstitial fibrosis, fibrosis between the myocardial cells. This one, wrong. No, this is due to viral myocarditis. Oh, endomyocardial fibroelastosis. Well, isn't that a mouthful? This is a disease that we don't see in New Zealand. It's very interesting, actually. So in African countries, green bananas, plantains, are a big part of the diet. They provide the starch that is needed for carbohydrates. Sometimes in people who have a susceptibility, it can lead to fibrosis of the right heart, right ventricle. more than the left ventricle actually, and so they get a stiff heart. I know this is one of the world's rarest conditions, but you'll probably remember that because that's how human memory goes. Amyloidosis, this is the thing that causes stiffness. It causes restrictive cardiomyopathy, just like endomyocardial fibroelastosis. And then there's healed myocardial infarction. Well, no, he probably doesn't have that because he doesn't have very bad heart disease. So this 78-year-old alcoholic has interstitial fibrosis. All right, let's move on to hypertrophic cardiomyopathy. So as I said, it can be a primary disease, which is mainly asymmetric, or a secondary disease, which is mainly symmetric. In other words, the whole heart is increased in thickness, and that's due to hypertension. This is a typically hypertensive heart. Okay, so here we go. We've got a big thick heart here. This should be about half this thickness. And it's just increased because the heart is working hard to pump through a very small valve. You can see here that it's got a tiny yellowy look. That is because of the fibrosis that's happening in this heart. So the people with hypertension go through a phase where they have really, really dense, thick heart muscle, but then the heart muscle becomes fibrotic, and so the heart dilates again, and they end up in dilated heart failure. This is what it looks like down the microscope. All this fibrosis that happens from viruses and toxins all looks the same. What happens is we get dead myocytes that are just replaced by fibrosis and poor contractility, poor systolic function. So this is the second kind. This is the inherited kind of cardiomyopathy. Here we go, a thin wall here and this thick wall here, often called HOCM, hypertrophic cardiomyopathy. And it too is caused by, two things. The first, it's caused by hypertrophy of the actual myocytes, but also by fibrosis. This is really important to know about. It's really important to know about people who have sudden cardiac death when they're young, and this is one of the causes. Lots of people who have cardiac death when they're young have abnormalities in their muscle proteins. Okay, so everyone who has a cardiac death now, it's really important if they're young, when they have the cardiac death, that they get genetics done, because it's autosomally dominant inheritance, which means that their brothers and sisters and children can be monitored to see if they have this disease and treated. Okay, so HOCM is about familial in 55% of cases. The rest are sporadic mutations. You don't have to remember the proteins. What you have to remember is that the proteins, particularly the myosin and the troponin, can have mutations in them. Okay, and these mutations can cause this hypertrophic cardiomyopathy, which can cause death. It just stops the myocardium contracting properly, and can also decrease the cross-sectional area of the heart valves. So here's a question. Jason is playing rugby. When he stumbles, falls to the ground, stops breathing, and is unable to be revived. He had a sudden cardiac death. Okay. So what is he most likely to have died of? Well, we've just said this: hypertrophic cardiomyopathy. Here we have Laura, who is collapsing during a half marathon. Again, Laura's heart is noted to be grossly enlarged. What kind of things might be seen? Well, I think she's probably not going to have a thin, floppy ventricular wall unless she'd had previous viral myocarditis. She probably shouldn't be running marathons and would have had symptoms of chronic heart failure before she began the marathon. The valves, there's another talk on valves soon. You might have watched it first. Yes, this is a disease of old people, and Laura is, no, we don't know how old she is. I presumed Laura was young because she was running the half marathon, but older people do it now. Anyway, she didn't have evidence of a myocardial infarct, a murmur as far as we know from her aortic stenosis, which is caused by these vegetations. Okay, so she probably wasn't running the half marathon with coronary arteries that show near occlusion. Most likely, she had a stiff, asymmetrically thickened ventricular septum. All right, so a bit of clinical reasoning there. Let's think about restrictive cardiomyopathy. Okay, restrictive cardiomyopathy, this is the third kind, all right? So remember, we've done dilated, caused by viruses, alcohol. We've talked about hypertrophic, primary and secondary, where young people die suddenly because of the asymmetric enlargement on the septum. Now we're talking about restrictive cardiomyopathy. Right, this is where the myocardium becomes very, very stiff. All right, so early on in the disease, they can have normal systolic function, but what happens is the infiltration keeps going. Okay, they get more and more accumulation of the abnormal substance or scarring of the endocardium, like that one that we discussed earlier, the endomyocardial fibroelastosis. Okay, so what things commonly infiltrate the myocardium? Amyloidosis. So amyloidosis, the production of amyloid, can occur due to light chains and multiple myeloma or secondary amyloidosis, okay, often due to a chronic inflammatory process or age or sometimes a bad gene. Okay, so amyloidosis can kill by deposits that occur between the heart cells, preventing them contracting. Here's a picture. I know it looks like the fibrosis picture, but in fact, this is a slightly different color and is amyloid, but it has the same effect here of abnormally affecting contraction, because it's just not compressible. It just, the myocytes just like they can't squeeze shut, and so there's no pumping action. The second thing that commonly causes a restrictive cardiomyopathy is sarcoidosis. So what does sarcoidosis do? Sarcoidosis causes granulomas to form here in the myocardium, which causes this restrictive cardiomyopathy. They can also infiltrate the conduction system, causing ventricular arrhythmias and sudden cardiac death. Okay, that brings us to the end. So we've talked about ischemic heart disease, revising mainly from previously, but also importantly relating it to the time sequence of people who will die after a myocardial infarction and what they will die of. We've talked about cardiomyopathy. We haven't talked a lot about heart failure. I'm going to talk about that when we talk about valves. Okay, so stopping sharing here. And I think that brings us to the end of the talk. Oh dear, I'm just like messing things up a bit here with the Zoom, but don't worry about it. I'll see you in the next lecture. I'll have sorted it all out by then. Bye.